I'm always excited to be able to talk Medicaid, but I'm really excited because whenever you can take long-term experience in program administration and things like that and layer it with a clinical perspective, like Dr. Fotinos has, that's when, in my eyes, real magic is able to happen. So with that, I would ask you to help me welcome Dr. Charissa Fotinos. Green means go.
Thank you. Good morning, everyone. This is a broad landscape view. So I take no offense if I can't see you. It's just the way the room is. So good morning, everyone. Thank you for the invitation and being here. I, too, find discussions about health policy fascinating, and hopefully, as we have this discussion this morning, I will not necessarily repeat things that you already know, though I will do that. Hopefully, I will give some information about what Medicaid is up to, the Healthcare Authority specifically, and how we are viewing the next period of time as far as Medicaid is concerned. And I believe we'll have some time to chat as well. Probably we're starting. We've recently taken a look at our strategic plan, updated our vision, mission, and values. And these are all pretty self-explanatory and straightforward, I think. We vision a healthier Washington, and healthier in the broadest sense. And that's not just about better medical care, that's about hope, health, wanting to be where you are when you wake up in the morning, and looking forward to what life has to bring you. So it's a much broader vision of health. Our mission as an agency that is a steward of a lot of tax dollars is to provide high quality care through innovative health policies and purchasing strategies. And I would be remiss if I sat here and said we've got the purchasing strategy piece figured out. We don't. We are trying new things. We engage frequently in conversations with our national partners, our different experts whose job it is to look at the healthcare landscape and figure out better ways to purchase things. And as a primary care provider, I know that when I see a patient, I don't really notice their insurance. I only notice their insurance when I have to write a prescription for them. And that used to be because we had 5 managed care plans, and I would have to figure out the formulary for whatever that patient needed. We now have a single formulary, which one could debate the benefits or disadvantages of that, but from a provider perspective, that's huge. I don't have to figure out what medicine for this person's asthma they need, and the next person needs a different asthma med. So I think we have to rely on both our providers, primarily our clients, our patients, to tell us what they need. And then from our perspective, how do we help work with our partners who we pay to administer Medicaid, as well as our legislative authorities in the governor's office to really help make things happen. And it really is a dance of a lot of people. Our values are straightforward. I think that want to highlight health equity, as well as diversity and inclusion, and not because that's the important thing to do, but as you look at who is covered by Medicaid, it is primarily people who are poor, and that it is also largely folks who are disproportionately represented by the color of their skin or their race. The numbers of people who are Black and covered by Medicaid far exceed the number that they represent in the population. So we are truly caring for a group of folks who start out with less support than many of us have the luxury of having. We're the largest healthcare purchaser. For every person that is not covered by Medicaid, the Healthcare Authority purchases care for 1 in 3 Washington residents. And that's inclusive of the Medicaid plan, Apple Health, the Public Employee Benefit Program, as well as the School Employee Benefit Program, about 2.2 million people, which is increased, and I'll mention that, about 400,000 since the advent of the pandemic. I sort of talked about this, our approach to healthcare purchasing, transforming care through better health and better care at lower cost. And that, as I mentioned, remains a challenge, given that healthcare costs keep rising. We're asking providers to do more. There are fewer providers who are able to keep up the demands, and in general, kind of a grumpy workforce for a variety of reasons that are, readily understood. So it is a time where we have to be more deliberate, more thoughtful, and really think carefully and hard about, are we making the right decisions? Are we investing in the things that demonstrate the best health for the most people? I think the other thing is whole person care. If I could wish one thing for my time in this role, is that when I am done, we don't talk about integrating physical and behavioral health care. We talk about health care. I'm a family doc. We're all connected. And so I hope that we can get to a point where that just falls seamlessly out of our mouths, that we're talking about people and what helps support their health, whether it be something to focus on an emotional or a substance use disorder issue, or a broken leg or heart hypertension. So I hope that as we continue to move through this journey, we can get to a point where we talk about health and not have to talk about integration. And data is important. We know that we, as a state, lag behind in terms of our connectivity and our interoperability for health records. We need to continue down that path to assure that small providers and big providers can talk to each other. People who are struggling to buy food cannot necessarily live in the same place forever, and so they have to move about. And the less that we have providers able to connect to each other, the more redundancy, the more things get duplicated, and the less quality care that people get. Our approach to clinical quality, we really try from the Healthcare Authority perspective to think about how we purchase health and what it has evidence to support paying for it across all of our programs, Medicaid, the Public Employees and School Employee Benefit Program. We use science, we use evidence where it exists. We try to be as innovative as we can and do pilot projects really around chronic disease management. I could talk for many hours about the opioid crisis. I won't, because that's not what I was asked to do today. I will mention it a little bit later. And we want to support the payers that we work with in allowing them to be innovative and creative to support the health of folks. And we also recognize that there are things in which it doesn't make sense to compete about. And I think that's something that we continue to think about all the time. How can we make it easier, first for patients or clients, secondly for the providers who do the work of caring for them, and then how do we help support people to demonstrate their value to people who get to choose whether or not they go for that plan. So I think it is, again, sort of an intricate dance. The other thing I would say, we talk a lot about science. I had the pleasure of attending the University of Oxford to get a degree in evidence-based healthcare. I've always found sort of that academic thinking approach really interesting. And as I was reviewing these earlier this morning, I think we have to be, I've become more cognizant that science is important. Evidence, when we have it, is instrumental in how we make good decisions. And thinking of our tribal partners, they are included in evidence. They have century-old practices that care for their communities, I would argue, better than a lot of the folks that I work with are able to care for theirs. So there is the science, but what can we learn from centuries of culture-based traditions and ways of healing? I think we need to do a better job incorporating what others have to teach us, because not everything's going to be a book or be studied, especially when you're not a person who can get to the research center and fill out all the forms because you can't show your ID, because you don't have a car, because you slept under a bridge. So I think we have to, again, be thoughtful and more inclusive. This is just a picture that shows the different groups of Apple Health enrollees. I don't need to say these King County's darkest because it's the most populous. But as you can see, we have about for adults, about 80% of folks are in managed care plans, and then 20% are fee-for-service. And that fee-for-service population is largely our tribal, Native American, Alaskan Native members, as well as people who are dually eligible for Medicaid and Medicare. So Apple Health expansion. In 2022, the legislature directed us to explore and move towards standing up a program that will cover people who are not eligible for federal programs for their insurance, or qualified health plans to stand up a look-alike program like Apple Health for this group of folks. And so we have been working on that. It will mirror Apple Health where it can. There may be some things that are carved out, like dental, which is currently the case. One of the things that we understand that is important, we'll need to work very closely with our community partners, advocates, is to make sure that the care is culturally appropriate, that we focus on equity, and that again, this is an ongoing conversation. How do we help support folks who don't have citizenship here, that we want to assure their health is good, or support it as best it can, so when they finally are able to access care, it's not at end of life or when they have a cancer diagnosis that they were afraid to go get taken care of because of the bills they would owe. So that is ongoing work. We hope to have that program up and running in January of 2024. The process as to how we will go forward with the procurement of that is still under a little bit of discussion. So I will just leave it at that, but we should have some straightforward direction and plan that we can share with all of you in the next couple weeks. Reprocurement of managed care contracts. It's been about 10 years since we last procured our managed care contracts. We have a large population, as mentioned. I was a little off, it's 84.8% are enrolled in the 5 managed care plans. And really, as we think about reprocurement, the plan for reprocurement is to have the RFP out, I believe, in, I'm going to mess it up. The plan is to start with the new plans in January of 2025. And I don't want to get the dates wrong. So why are we doing this? It's been a while. What's important to our minds as we think about this? I think it's really, how do we be thoughtful about what we want to pay for, how we want to pay for it, with really a lens on how do we best support the people who need to use the services who are covered by Apple Health. And we can't help those folks unless we support the providers who are providing their care. So how do we make their lives easier? Are there administrative simplifications that we can look at and be more deliberate about as we procure this time? So that, again, folks are competing on things that make sense to compete, but you know, the form someone uses shouldn't have to be that different. And recognizing that that's incredibly complicated, because all but one of our plans right now are national plans. And I suspect, you know, national headquarters of the plans really don't care what Washington does too much. They might. But so we have to keep that in mind. So, but I think really our focus will be on equity, assuring that people have access to all the services they need, and that providers have as much as possible as little sort of administrative work to do to be able to deliver care. Kind of talked about this, aligning and improve managed care is our goal. We want to continue to improve whole person, I don't like that word, improve health. I'll just use it here since I explained myself. We want to assure that quality, accountability, and care coordination. And I'll talk about care coordination here for a second, because I think one of the things that I had the benefit of training in a program in Seattle where we had, I don't know if those of you familiar with Wayne Caton, he was sort of the guru, one of the founders of the collaborative care model. He came to our clinic every Thursday as our behavioral health consultant. And so I learned behavioral health from Wayne Caton, and so if I had a patient that didn't want to seek care in the community mental health center, I could, with Wayne's help as a psychiatrist, help manage that person's medication. And I had a social worker just across the hall from him if that person was in a domestic violence situation or needed food. And I just thought that's how primary care worked. You know, you had your social worker here, you had your home nurses there to go see, you know, struggling teenagers who just delivered their babies, who couldn't stay with their parents and had to go find these kids and their newborns, and I just figured that's the way it was. That's not how it is. And I think it's become apparently clear to those providing care, as well as probably most of you in the room, that we're missing that glue. Our care teams don't have that glue that helps bridge that gap between what happens in the sort of sterile healthcare setting versus how that person lives 95% of their life, which is out in the community. So that's community health workers, peers, promontoras, patient navigators, a variety of words. Folks need people that look like them, that can relate to them, understand them, so that they can be better supported through achieving health, not just in our clinical system, but more broadly for social needs as well. which is not necessarily all the goal of the reprocurement, but I wanted to highlight care coordination. And I think we want to, as I focused on before, reduce administrative burden. We want to align our waiver activities with our Apple Health expansion procurement that I just mentioned, along with our reprocurement goals, so that really we are taking a step back and looking at the health system across the continuum of care and trying to make sure that we are being deliberate and thoughtful in how those pieces fit together. And we're not just saying, okay, reprocurement, all right, we did that. Let's hop over here, 11:15, let's do that. It's really much more thoughtful and deliberate. Federal public health emergency unwind, the best we know that's going to happen in January. As I mentioned, that'll be 400,000 people transitioning if things stay the way that we anticipate now, about 400,000 people who currently have not had to renew or had to pay premiums if they were in certain groups. That will end. We plan to do that unwinding over 12 months. So it will be a steady renewal process each month. We've been planning for this along with many other states for months. We've been working closely with our partners at the Health Benefit Exchange to make sure that for folks who may have aged out of Apple Health who are now eligible for Medicare, or for people who may lose their Apple Health coverage, that they are connected to the Health Benefit Exchange to see if they have a qualified, if they are eligible for a qualified plan, qualified health plan. And also we're working closely with our managed care plans. We want to make sure that we know how to find people and inform them that, look, you're up for renewal next month, please let us know. And working with our provider community, I would have patients bring in their form and say, who are these Molina people? And I'm not picking on, I think I saw Jay there, I'm not picking on anybody, but it'd be like, well, that's your insurance company. Well, who are they? You're my doctor. Well, no, they help pay for your care. Well, do I have to call them? I don't know them. And so I think when you distill it down to the patient, they may not have as much appreciation for what particular plan delivers their care. So I think that we have a huge partnership with our managed care plans to help them engage with their members so that they can understand what they need to do as the public health unwind happens, along with providers. We suspect there will be perhaps a 5% increase in the number of uninsured. We will see. Inflation's thrown a wrench in that, as has the rest of the volatility of sort of our environment. But this is going to be the biggest piece of work our agency has done since the Affordable Care Act. But our underlying goal is to assure that no one loses coverage that they would otherwise be eligible for. Our transformation project, we submitted our renewal for our second version of our Medicaid transformation project. We submitted it, I believe, in July. We had a preliminary call with CMS yesterday, just making sure that they understand some of the things we were asking for. It will be the first of many calls with them. This current waiver has been extended. It will likely be extended beyond December just because CMS is trying to manage a lot of waivers from a lot of states, so the timelines may be a bit delayed. And looking at $1.5 billion as part of that. Again, focusing on whole person care and really how do we both connect people and support them who are seeking health care in whatever facility they're most comfortable with. But I think one of the focuses of this iteration of the waiver is how do we help support people who may be covered by Medicaid but don't seek health care? Maybe they've had a bad experience, maybe they're afraid, maybe they're intimidated, but they might need food, housing, or shelter. How do we help build up that sort of social determinant support using our community-based organizations, our managed care plans, and our accountable communities of health to really help provide a different entry into supports for folks, and broadly speaking, health supports, whether that be direct clinical care or not. So continue to move towards more value-based payment and outcomes-based payments for quality. And continuing to expand, there's been some really great work across the state with the different coalitions that the Accountable Communities of Health have brought together, and particularly some of those shown during the pandemic and how they came together and delivered vaccines to folk, delivered food to people. So I think that there's more work to do, but I really appreciate all the hard work that the Accountable Communities of Health have done, and I think we can continue to build on those to be really strong community changers, agents, along with our public health departments, who also have struggled a lot during COVID, but are important. They're important to their communities. They're important to help assure that sort of health from a public health perspective. So what you're hearing a theme with me say is we have to do more of a team-based sport than perhaps we have in the past, because we really need to help support folks all the way around. Trying to improve access to mental health as well as substance use disorder. I see a number of discussions later talking about both children, adolescent, and adult mental health. Behavioral health services across the continuum. I looked at this morning. I said, I would have maybe, if I'd been more thoughtful, changed this a little bit. I think, prevention is key. Early recognition. Intervention sounds like the TV show, and I might soften that a little bit, but I think really recognizing when people first start to struggle is important, and whether that's people, young adults with first episode psychosis or something else, the earlier we can help support someone and help figure out what they need to walk their path most successfully, the better it is for all of us. We continue to have inpatient, outpatient treatment and recovery support. And I think one of the things that, again, is not a focus of this conference is we really have to recognize that COVID is a public health emergency, so is the overdose crisis. And that's both from fentanyl and stimulants. And that treatment starts with engaging someone who is struggling with a substance use disorder. Some people call it harm reduction. I call it treatment. If I see a patient and I give them a high blood pressure pill, I'm not curing their high blood pressure. I am reducing their risk of dying in 5, 10, 20 years from a heart attack or from congestive heart failure or a stroke. I don't cure them. I help lessen their risk. So when we outreach to people who are struggling with substance use disorders and we provide them ways in which to do that more safely, we provide them with overdose reversal agents for themselves, their family, their friends, we are providing treatment, we are providing care to them. And so I think we really have to be more thoughtful and expansive in the way we think about that, because fentanyl is potent and it's killing people every day. And I think we have to think about it differently. It's a very different drug. It requires different interventions and a completely different frame of mind to figure out how to help support folks who are struggling. And recovery support. I see my fellow HCA folks who run the behavioral health division over there in part, and we need to work together. Funding sources, I see Carter leaning forward. So where does that leave us? I think, as I think about the future of the safety net, income inequality continues to widen, and that will continue to move forward health disparities. I think we have to be mindful of that. Health equity I mentioned the drug overdose crisis. Climate change. We saw it last winter with the floods, trying to get people their methadone or other medications by boat because the clinic they couldn't get to. Heat waves, fires, those are going to impact people who are poor and less resourced more than others. Healthcare costs, that goes without saying. High-cost drugs, and I'm not talking about just the price of insulin. Some of the new drugs that are groundbreaking to treat cancers that are very, very rare are $1 million to $2 billion a dose. Where do those fit? How do we do that? How do we consider that as we're trying to take care of populations? The workforce, I suspect there'll be a lot of conversations about that. People are tired, they're stressed. It's been a hard couple years for everyone, and particularly in the healthcare sector workforce, on the behavioral health side, the physical health side. Small mom and pop shops are closing. I think we really have to devote a lot of energy and thought and creativity to help support the workforce. And I think, as we are reminded lately, both in the newspaper and in conversations, right now the hospitals are full of folks, not from COVID, but because the folks who are there are complicated in their medical histories, their behavioral health histories. They may not have a home to go to. Our post-acute care system is stretched, lost a lot of staff. So how do we help continue to improve the movement of folks through the healthcare system as we go forward? I think those are all current challenges we face.
Where to start, right? Like, there's so many things. I hope your coffee has had the ability to kick in. I had mine very early this morning. So, little quick housekeeping piece. There are 2 microphones right here on the floor. This is the call to action for us to get some questions. We're going to keep talking until somebody comes up there. Where I'd really like to start, and it's one of the things that you touched on, but maybe just expand on it a little bit. is that Apple Health expansion, right? There obviously are these populations that exist out there. How is the agency approaching or anticipating what that population looks like? And maybe what are some of the special needs that potentially that population has?
I think, largely we're talking about, again, folks who are not citizens of the state and not eligible for federal programs. So separate from refugees who aren't political asylees or formal refugees, I think we're thinking about folks whose primary language is not English. And so really, I think our task and our challenge is to get out into the community, to use our community service offices across the state to work with our partners at the Department of Social and Health Services to really, they're the ones in the community. Who are the folks that we're not reaching? How do we reach them? And so I think strengthening partnerships and community collaborations and understanding the needs. I mean, I can pretend I know, but I don't know. So really asking folks, what do they need and how can we best get it to you? So I think a lot more outreach, perhaps, than we may have or have not done in the past.
Well, and I think, the beauty of that conversation, especially for a room like this one, that's also a call to action to all of you, right, who are interacting with those folks potentially on a daily basis, right? And so what is it that does need to be accounted for? And I think that's a yeoman's effort, and the work that goes into that is crucially important. Touch a little bit, I know how passionate you are about opioids and just the crisis. Where do you think the highest priorities, I guess? I mean, it's so broad and the issues really come in, but where are the highest priorities for the healthcare authority and where it concerns opioids and substance use?
Are you asking if I had a magic wand or realistically?
How about one of each?
I think I don't know. I don't have the answers. I do think that a priority beyond the healthcare authority, I think, for all of those of us who are work in the field of healthcare, concerned about healthcare or the health of folks, I think probably the single best thing we could do at a population level is to continue to reduce the stigma around people with both mental health and substance use disorders. These are not choices that people say, oh, I think I'm going to have a fentanyl use disorder today. That's not how it happens. I mean, particularly if you talk to women who struggled with opiate use disorder or stimulant use disorder, the vast majority have had horrible traumatic events in their life. And that's true with a lot of men. So it's not the behavior now that we have to think about. It's what was the path that led this person to this seemingly being their only option to get through the day, because that's a horrible day when that's where you end up. And so how do we help more compassionately and provide more empathy and kindness to folks and hope? I mean, to me, that's the single biggest thing we could all do, so that when you want to have folks in recovery live in a neighborhood, you don't have the neighborhood up in arms saying, no, those people can't come here. Nope. Well, those people are our people. We are, it is us. So I think, I think that sort of destigmatization is a big part of that. I mean, there's other tools, but.
Sure. I'm serious. There are two microphones right there. They're turned on, and they're not going to shock you. Another piece that I know is of interest in an area federally, right, that's getting some attention is kind of the connections or transitions between Medicaid and people in the criminal justice system. Can you touch on that just a little bit and talk about some of the initiatives there?
Sure. I mean, we know that probably the easiest example, again, of course, relates to opioids. We know that when folks are leaving places of incarceration, if they had an opiate use disorder and they have been incarcerated long enough that their tolerance is gone, they will leave, whether it's prison or jail, go out, use, thinking that, oh, yeah, I used to use this much and more all the time, and then overdose. And so there are significant healthcare gaps in that. So, and not just for people with substance use disorders, but people with chronic illness, people with mental health, they lose their Medicaid coverage when they're incarcerated, and then we suspend it, but we're finding we still have some sort of challenges in our system to be able to turn even prescriptions on right away for that person who's leaving. So we are hoping to talk with CMS about turning on Medicaid coverage 30 days before someone leaves a place of incarceration, or in the case of a jail, not turning it off, as it were. They repeated those words to us yesterday on the call. I think other states are trying to do that. So really trying to assure that people can access the health care and the medications they need in that transition, and really focusing on that big care gap.
That's great. We do have a question.
Yeah, hi. Could you kind of go through a likely scenario of the unwinding of the public health emergency, and would there be a grace period for people that are currently enrolled?
Yeah, so the way, I will do the best I can to not misspeak here. Everybody currently renews on an annual basis, and so the plan is, as that person's renewal time comes up, prior to their renewal time, there'll be outreach. I think we're actually doing a pilot with some postcard sending to folks. I don't know what color we picked, but it'll be a very bright color, like "Pay attention to me." So really trying to start to get information to people, and even having providers now say, hey, if you haven't gone in and updated your current phone address information, if you have one, with Medicaid, please do that, so that when it's time for renewal, we can quickly say, what's changed in your life? Nothing. I don't have any change in circumstance, and then they don't get turned off. We keep going on. So it's really getting people information before they're up for renewal, doing all those renewals. There will be a grace period for folks to appeal a decision if they do, in fact, lose their coverage. But again, and I can't tell you off the top of my head how many people will have to process a month. It's a lot. If they're 400,000 over 12 months, it's, 30,000? It's a lot, 30,000 a month. So we will have to hire more staff. And I think one of the things that we internally are thinking about, and how do we support, most of our workforce has never done eligibility redeterminations because they haven't had to be done for 2 years. And so we have staff who've never had to do this. So a lot of training is happening, a lot of planning. We've been planning for this since, probably the last 8 or 10 months. So I am happy to connect you with folks who can give you more specifics if that wasn't really adequate. But there is a thoughtful plan that will sort of regulate the best we can. And again, working really closely with our partners at the Health Benefit Exchange and our managed care partners to assure people don't fall through the cracks.
Okay, question over here. Introduce yourself, and then question over here, and then we're going to call it. So nobody else go to the mic.
Will Rice, Catholic Community Services. Thanks for being here, Dr. Fotinos. You mentioned the crisis of the hospitals with folks being staying there for, as I think hospital folks say, non-clinical reasons. Do you foresee Medicaid moving forward with the new waiver, investing more in medical respite or home health in non-traditional home settings to help take some burden off the hospitals?
Great question. So we have, I think everybody could hear the question. We have added medical respite services in as part of our waiver request. I think one of the things that we're finding is that a lot of the people that are in the hospital for these prolonged periods, they're not necessarily folks who can live independently. They may be folks with multiple medical problems that would be beyond the ability of a respite program to care for them. They may be people who have had a traumatic brain injury, who have behavioral challenges. So I think a lot of these folks are representing with a set of needs that we haven't really had to encounter in the volume we have. So, but we have asked for respite. We are also looking to shore up our home care services. And there's no mystery that Medicaid rates are not comparable to Medicare rates. And so we continue to work and try to be thoughtful stewards of the money that we have, but also to figure out how we can best align how we help support folks who are on Medicaid who have complex problems and often multiple problems in a better way through continued partnership with the governor's office and our legislative authorizing environment.
Perfect. Last question.
Yeah, I'm Representative Rob Chase, but one of a few of the big factors in our healthcare crisis are, well, people live longer for one thing than they used to. Another thing is nutrition and exercise. We're reacting to, instead of preventive maintenance, by how do you do that without being coercive?
You're right. I during COVID wore a public health hat for a couple years, and it's, as a family physician, prevention is a big part of what we do, and I think that, and I think of my behavioral health colleagues, prevention is first and foremost. And I think, again, because my purview is Medicaid, the folks who have Medicaid don't necessarily have the opportunity to buy the same kind of foods, especially with inflation, that I do. They don't necessarily have the same options. And, I live in Seattle, and just hearing the news in Tacoma and Seattle, you're not going to let your kids play outside anymore. It's not necessarily safe. So go run around the park, maybe, maybe not. So I think there are a lot of ways in which we have to think more broadly than just come in for your annual physical and let's do prevention. How do we continue to work to making our communities safe and having people be a little bit more collaborative, and that, we'll do better if we all work together and care for each other in whatever setting that is. But you're right, prevention is where we need to get to. I agree with you.
I want to thank you guys for coming today. Dr. Fotinos has done a tremendous job. Your brain juices should be going on full blast right now, which is a great way to start the day. We've got a full day of really quality sessions. We ate into your break a little bit, so your bathroom breaks have been abbreviated. But breakout sessions are next. We'll have 2 tracks there. And then we're back in this room for lunch. So please join me in thanking Dr. Fotinos for her comments, and we're adjourned.